performing a Deuk laser disc repair today on a patient who has basically a lot of things going on with her spine, but it's easy to get distracted. We need to focus on what's actually causing her symptoms. And she's having back pain from two herniated discs, the L3-4 and the L4-5, as well as from the facet joints. And when I first saw her, we figured out that was her left L3-4-4-5 facet joints. But then when I saw her yesterday again, it was also the right side. But today we're only doing the left. She knows that. She's awake. And we're going to get started. We may have to bring her back and do the right side another day. All right. Let's see. So far, are you comfortable? All right. I'll put you to sleep as soon as I can, all right? So we need to get to 3-4, which is right there. Shot. 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 Let's get an AP. You're doing good, okay? You just lay still and that'll make things go much quicker and easier. Yeah, that's what I thought. Need to be a little more lateral. Just lay still. I'll give you some more numbing medicine. Huh? Little num num. Little num num. You like that? I'm sure you've heard that before. Right? At the dentist? Is that what they say? No. Maybe that's where I heard it. What? How's her blood pressure? That's reliable? Shot? We can't put you to sleep yet. We need your help. Shot? I'm going to put you to sleep soon. AP? Don't worry, we'll put a quarter in the anesthesia machine in a moment. All right, so, yeah, that's better. You can see the scoliosis going on there, but that's not what we're here to fix. The scoliosis is not causing her any pain. Scoliosis is just an abnormal alignment of the spine twisted to the side. It comes from lateral aesthesis. But fixing her scoliosis will not fix her pain. Fixing the painful disc will fix her pain. Shot? And that's what we're going to do today. We're going to fix those bad discs. Shot? You can see the tip of the needle is heading right towards shot, that L4-5 disc. Shot? All right. Everyone agreement? That's 4-5? You know, they call it needle jockeying for a reason. I never understood why they call Dr. Patel a needle jockey. All right? And then I started using needles myself, not on myself, but as a neurosurgeon, we don't really use needles that much. We use scalpels and lots of other equipment, but needles are not commonly used in neurosurgery. But to get access to the disc and the herniation, you got to use a needle. And that's not something we're taught to do as neurosurgeons. We're taught to make a big incision and then peel everything open off the spine. So learning how to be a needle jockey to do these endoscopic surgeries was something new for me many years ago when I started, and it was not taught to me in residency. But, you know, you learn that the needle, these are very special needles, first of all. Very, very, very special. And you have to do things with it to get it to go where you want it to go. And you can actually crawl around within half a millimeter, quarter millimeter of where you want to be. Using that x-ray machine, as long as you've got a good x-ray, you can actually see like little places and spaces and get the needle to go where you want it to go. All right, that said, enough talk about needle jockeying. I will just say that I used to laugh at the idea of needle jockeying, and now I respect the needle jockeys a lot more, right? Yeah, she agrees. Sean? Okay, so we're going for 3, 4, 4, 5. Everybody in agreement? Sean? Oh, you're okay. Come on now. I know you're tough. Sean? That's your facet, by the way. That's one of the ones we're going to fix a little later. Sean? Uh-huh. We know that's an arthritic facet. Don't move. So she has a, watch the needle there. She has a very low, what is this? No. Come on, man. Pay attention. Yeah. Pay attention. We're not in the disc. That's a discogram. You can't just be handing things. You got to understand where we are. Shot? All right. Shot? She got some pretty bad arthritis. Shot? Lay still. You can feel that facet is huge. Shot? Shot? Give me an AP. We've got to be above the TP. I feel like I'm hitting the TP. Transverse process. I am. I knew it. They were way too lateral. That's why it didn't make sense. So we're actually touching the TP there because of the scoliosis. Okay. Shot. There we go. Shot. That's better. Shot. Let's get a, let me see, just a little more. Lay still. Let's get an AP. So when I ask for an AP, I'm asking for an x-ray that goes front to back, as opposed to a lateral, which is side to side. That's much better. Once again, you can see the curvature of the spine. And again, we're not here to fix scoliosis. We're here to fix two painful discs. Okay, just about done. Shot. Where do you feel that? Where do you feel that? Is she responsive? All right, we've now placed the two needles through the foramen, and they are literally inside the tear in the back of the disc where the herniation is. How long has she had back pain for, ladies? All right. I want you guys to know how long the patients have back pain, okay? So basically, how many years? 7 plus. Yeah. All right. When somebody says they have 7+ years of back pain, what they mean is that it's really gotten bad in the last 7 years. So we'll just say 7+. 7+ years. It really means they've had pain probably like more like 10 or 20 years, but inconsistent, and it's been consistent over the last 7 years. So her back pain on examination when I checked her out, it was in this area, and also it was off to the side, both. So we know she's got herniated discs or degenerated discs at L3-4 and L4-5. She has a tear in the back of L3-4, a tear in the back of L4-5 on the left side, and a bulging disc here and here. All right, are you awake? My belief is that these bulging discs with tears are the cause of most of her back pain. How's she doing? All right. We don't need these here, right? Any questions from the audience?
No current questions.
Henry, would you mind running our video that will show the audience why do people get back pain from an annular tear, herniated disc, or bulging disc?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. All right, so we haven't done much yet. We're waiting for you guys to watch the animation. We're also waiting for our patient to wake up a little bit. How is she? Are you awake?
She said yes.
All right, are you comfortable? So we're getting ready to put her to sleep for about 30 minutes while we fix the two discs. And I want to make sure she's comfortable. I also want to do her discogram. So we're gonna see just exactly what happens when we do the discogram. Are you comfy? We'll start with L4-5.
She said yeah.
All right. Reliable?
Yeah.
You see that? How bad is that on a scale of 1 to 10?
What number did you give it?
I heard 9.
9.
And is that where you typically get back pain? Yeah. All right. So she has a 9 out of 10, concordant. And Jordan, will you show the audience? Can you stay on the X-ray there? Yeah. Show the audience the tear in the back of the disc. Yep. And show them the dye leaking out in the epidural space right there. Yep. Perfect. So there's a huge tear here at 4-5. She has a 9/10 pain. It's concordant, meaning it's her typical pain she gets every day. All right? Is that better? So remember, it only happens when I put some pressure, but you could actually see her back come up. She was like, ah, and then you heard her. Are you better now?
You better, man.
Yeah, she's better. All right, are you comfortable? Are you comfy? Yeah. Sorry. How bad is that on a scale of 1 to 10? Show them the dye leaking out. Stay with the X-ray again. You can see once again a huge tear in the back of the disc with the dye leaking out. All right, so that was a 10 out of 10. So she has 10 out of 10 pain at L3-4, and that's her typical pain? Yeah. That's her typical pain. So 10 out of 10 at 3-4, 9 out of 10 at 4-5. So we know for sure we're getting rid of a lot of her back pain by fixing these two discs today with the Deuk laser disc repair. And then, of course, we're going to do her Deuk plasma rhizotomy on the left here at 3-4-4-5 because I believe she has facet pain. I think it's actually bilateral, but we're only doing the left side today. All right, so we've got our guide wire. Let's take a shot. I'm going to remove now the needle and leave the guide wire in. Guide wires are developed by surgeons, and basically they're used to put in things like pedicle screws, or in this case to guide me through the transforaminal space. Lay still, you're fine, everything's okay. All right, so she's still a little lighter than we want her to be. Just lay still, everything's okay. Now you can see the dilator is right near the herniation, so that's why she's uncomfortable. We're going to wait a few minutes. We're going to give her a little more anesthetic, and we're going to let the dye do its job, because we also have inside that discogram dye some numbing medicine, right? And that numbing medicine will help ease the pain of doing the surgery on the disc. Let me know when I can proceed, doctor. So we had to wake her up to do the discogram, so she's still a little bit more awake than we want her to be. But she seems to be getting better. That's all right. Take your time. Just lay still, you're okay. Shot. Let's see where we are here. Yeah, we're right up against the herniation at L3-4. You can, yeah, that's fine. Just take your time, do it safe. You can actually see all that black dye right behind the disc. Jordan's showing it to you. Go ahead and go to the x-ray there. Can you see that arrow moving, Henry?
Yeah, we see it.
That's all dye that leaked out of the disc where we injected it in the center of the disc. It leaked out through a big tear in the back, and it's running along the nerves. So that just gives you an idea of just how easy it is for liquid to run out of the disc tear and up along the nerves. Yeah, it's nice. Shot. Okay, now we're going to move, and really what we're doing is pushing the herniation back into the disc. Is that it there? Wait. Let me see. Yeah, I think that's good. Go ahead. So we're actually passing this metal Dracula spike right through the tear where the herniation came out. And now that I've got the dilator there, I'm going to bring my tube down. It looks like a McDonald's chocolate or vanilla shake straw, not strawberry, just either chocolate or vanilla. And we're heading down the dilator, and we're going to put this inside her herniation, and this way we can get the herniation out using this tube. We're going to do the whole surgery through this little tube. Done. All right, let's move the x-ray machine out. By the way, we have another True Patriot, red, white, and blue. Hopefully you guys can appreciate that. She's all American. Of course, you know the white is the sponge and the blue is her blood. Just kidding. I get a few people with that once in a while. The alien blood. One time I got Dr. Berndash. I said, "You see all the blue blood?" You were freaking out when you saw that the first time, right? You were like, "Oh my God, she's deoxygenated, really bad. We need to oxygenate the patient." All right, so we're inside the herniation. You can see all the little pieces. It's kind of scraggly. Gentlemen, laser. You can see the tear at the top. It's blue. It's the interposed nuclear material. All right, guys and gals, I had that thin crust pizza today. It was pretty good. What do you guys think about it?
It was really good.
You like the thin better than the normal?
I don't have a preference. I like both.
I like the thin. I mean, I could use for less carbs, you know? Can we make sure that Karen orders thin from now on?
What is that?
Thin crust?
Thin
Oh,
crust?
thin
Yeah. I know you guys are always ordering Starbucks, but tell Karen we want thin crust pizza. All right. Here we go. This is all the herniation right here. Look at it undulating. Laser is just zapping it. This is a 1 millimeter laser. So the bigger laser fiber. Look at the tear right there. You see the tear? At the 12 o'clock?
Yeah, we see it.
Yeah. So that's what we're here to clean up. And again, this surgery you're watching, the Deuk laser disc repair, is the first surgery of its kind. No one in the world has ever described or thought of cleaning the tear. They all talk about, discectomy, taking the herniation out, herniectomy. But debridement of the annular tear was first described by myself. And that's because I figured out it was this tear that's actually the cause of all the problem. Okay? I'm not trying to brag. What I'm just trying to say is if you go elsewhere and talk to other doctors, they won't understand any of this stuff. They still think the herniation is all that matters. Pinching the nerve. They don't understand the mechanism of action of this pathophysiology of this condition, we call it. The pathological, physiological, anatomical basis of back pain. And they're still living in the dark ages, as I say, unfortunately. And patients are suffering because of that, you know? If you go and if you go to a dentist and your dentist can fix your teeth just fine but doesn't know how to do gardening, it doesn't really affect you because you're just there for your teeth. But when you go to a restaurant and the chef doesn't know how to keep the food sterile and clean and it gets infected, full of bacteria, that's going to be a problem for you. In other words, when the healthcare provider or person you rely on to provide you with the best of what you're trying to get can't figure out how to do that, then you're going to suffer. So doctors that don't know how to diagnose and treat chronic back pain, well, if you go see that doctor, you're going to stay in chronic back pain. You might even get worse because they'll try treatments on you that could hurt you. They don't work. What I'm getting at is we need to get everybody up to speed, you know. Anybody know what puerperal fever is? No? Nobody knows what puerperal fever. I'm sure some of our viewers know. So a long time ago, nobody knew about germs, and women would deliver babies. That was back in the day. And they would, deliver the babies, and the doctor would go around and put their hands in there and grab the baby and pull them out. And then they would go to the next patient and get the next baby out. Then the next. They would literally go around all day pulling babies out. They never washed their hands because they didn't know that there were germs being transmitted. And all these women would get sick, and they would have infections after giving birth to babies. And they called it puerperal fever. It was basically an endometrial infection. And the reason was the doctor was transmitting a bacteria from one patient to the next without knowing. Because, they had no idea they were actually doing that. And what I'm saying is that, you can't trust healthcare providers all the time because sometimes they don't realize what they're doing is hurting patients. And you've got to really advocate for yourself and make sure you go somewhere where you're going to get the very best care. Hold that tube. Yes. A lot of times doctors' lack of knowledge or lack of understanding of a condition can actually harm you, the patient. But I'm saying be advocates for yourself and educate yourself about the truth, because once the hospital figured out that puerperal fever was due to a transmission of bacteria from one patient to the next by the doctor, by the surgeon, by the OB-GYN. They made changes, and they started washing their hands to kill the bacteria. And then the infections went away, and they never happened anymore. But guess what? At the time, there were maybe 5,000 hospitals worldwide. Well, it all started in one hospital. So for a long time, it took time for that knowledge to be transmitted from one facility to the next. You know, for people to talk about it, report it, share it. And you can imagine it took some hospitals an extra 5 years, 10 years just to pick up on what's going on and finally integrate protocols into their OB-GYN procedures that would prevent infections from being spread. So my point is, we're at an interesting time when it comes to spine care, where we now know what causes back and neck pain, and we now know how to fix it. But not every hospital knows how to fix it. Not every surgeon knows how to fix it. So if you want to get fixed, you got to go to the right place. By the way, that pink area there is the surface of the bone. It's called the end plate. Now when you go to the hospital and you have a baby there as a female or whatever, I say whatever because I guess there are guys having babies now too, but anyway, when you go to the hospital and have a baby, everybody washes their hands. They wear gloves and a gown. It's done sterilely. It's done in a clean environment. But it wasn't always that way, and it took somebody figuring it out. Now, look, that's the tear right there, okay? That's what we're here to fix. By the way, I know we have some doctors from around the world watching these surgeries, learning my technique on endoscopic laser surgery. Just make sure that you're well trained before you try doing any of this on patients so they don't get hurt and they have good results. But we've had some questions today from some fellow physicians around the world. Stand by. Didn't get very much out. I need a few more minutes, 5 minutes on this disc, doctor. Oh, sure. Why not? The next disc. The fiber just isn't going where I need it. It's not terrible, but got to do a little bit better. What's the question?
No, just making sure they notify the patient. I think the patient's coming in too late.
Bring the patient earlier.
I don't think we'll be ready.
Well, yeah, we need the next patient should be here now.
Yeah, that's what I'm saying. They were not coming at 4.
No. They need him now. Call the next patient and bring them in now. I don't remember what the last. Yeah, Bernadette, that's exactly right. That's what you got to be doing. We'll be ready to roll back in 30 minutes with the next patient. Maybe 45 minutes. I have that rhizotomy to do. Okay, Henry. Why
Yep.
don't we show our audience what we do with the Deuk laser disc repair?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. What did we just watch? Why discs cause pain, or how the Deuk laser disc repair works?
How the Deuk laser disc repair works.
All right. So, for those of you who have ever dealt with chronic back pain, maybe you've been offered to have a fusion surgery done. And just so you can get an idea of what the difference between fusion surgery and Deuk laser disc repair is, watch this next video. It'll compare the Deuk laser disc repair with fusion, and you can actually see the difference.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-Strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
Welcome back. And now you are knowledgeable about the difference between open back surgery with fusion versus the Deuk laser disc repair. Both treat the same thing: back pain, pinched nerves, leg pain, neurogenic claudication, spinal stenosis. But one of them is far safer and far more effective with a quick recovery. The other one is a pretty big, involved, invasive surgery and loss of movement. All right, we're done with the 3-4. Now we're going to work on the next one, which is the 4-5. Alrighty, nice. Just relax. She's doing good. She's not even responding, so I think she's doing well, right? Shot. Pressure, pressure. Shot. And let's see what we got there. That looks pretty good right there. Shot. And take it out. Shot, is that it? Looks good. So a dilator is within the disc. You're fine, just lay still. We'll give you a little more medicine. Shot. Shot. Yep, we're perfect. All right. Whoa, everything okay there? Thank you. Well, her discs are pretty degenerated, so we're getting, you know, a little more haziness from it. That's just some blood from the inflammation. Take this. That comes from the degenerative process. All right, we've lost probably around 3 cc's of blood. And we have 5 more minutes to go, doctor? Oh, no, don't get it close to my face.
Yes, sir. Sorry.
Uh-huh. How's she doing? Good. Hmm? Yeah. Did you have a question? Huh? Doesn't have to be. It's just facets. So we've got another 5 minutes on this one, and then we're gonna be done, and we'll switch over to our plasma standby laser. Plasma RFA. Or plasma rhizotomy. I mean, it's not a radio frequency, it's a plasma rhizotomy.
Yeah, so tomorrow we do it. I'm gonna be here at 11:30, 11 o'clock tomorrow.
Yeah.
Check on the patient, get him ready. It was the last one that we did intubation.
Huh?
The last technical that we did was with intubation. Yeah, that's why I was asking. Yeah, I just want to make sure.
I don't know, whatever you want to do.
We just got a few questions.
All right, we'll take our question from the audience.
The first question comes from Wanda Jones on Facebook,
Hi, Wanda.
and she
Welcome to the broadcast.
asks, by putting the endoscope into the annular tear, doesn't
Yes.
that make the tear larger?
You know, that's a great question, Wanda. My gosh, I love good questions. Very astute. The answer is no, because the tear is already really big. The tear is actually huge. It's probably 5 times bigger already than the tube itself. The tube, remember, is only 7 millimeters, and the average annulus top to bottom is going to be around it's going to be around 2 centimeters. Let's see, that's 20 millimeters. So the tube is 7, it's 20 top to bottom on average, and then the width of the tears are very wide. They're probably around 40 millimeters. Grabber. So yeah, it's fine. So the tube is only 7. The width of the tear around the circumference of the back of the disc is around 40, and the height of the tear is around 20. So yeah, the tube is smaller than the tear always, except for a case we did yesterday where the tube was actually bigger than the tear. Actually, not yesterday, 2 days ago, I apologize. And that was the last surgery of the day. We did L4-5. Look at that, that's where all the inflammation is, the worst of it. Right there, at the back of the tear. That's what we need to get rid of. Anyway, that lady had a bad tear at 5-1 and a small tear at 4-5. And we went into the 4-5 and we fixed it. And that one we probably made the tear a little bigger than it was originally because the tube was 7 millimeters. The tear was probably around 4. There, look at that herniation. But I can tell you that's extremely rare, that the tube is bigger than the herniation. Bigger than the tear. Usually the tear is bigger than the tube. Almost always. Are you pinching it?
Huh?
Are you pinching it? Oscar, you're not pinching it.
Oh, yeah, I'm grounded.
No, I didn't feel it, and I went back in. There's still some herniation in the mouth. Yeah. Huh?
I'm doing delicate like you told me.
Yeah, delicate's fine, but you can't leave the herniation there. And I can actually see it when I put it back in. It's still there. So, does that make sense?
Yes, sir.
Yeah. All right. Just about done here with this disc. But great question, Wanda. No one's ever, I don't think anyone's ever asked me that. Have they?
I don't believe so. Yeah.
It's very a good observation.
We do have another question from YouTube.
Sure.
This
I'll take the other question.
this comes from Ben Price on YouTube.
Hi, Ben.
And he asked and this is a good question, if the annulus tear takes months to heal, what prevents further herniation through the original tear?
Yeah, great question. We answered this earlier, but the annular tear takes probably, I have to guess, about a year to heal. And you can see the disc is not water. It's not just going to leak out like a water does. It's thick and congealed, meaning it's stuck to itself. So you would have to do something where you put a lot of pressure on the disc And that would require some heavy lifting or bending. And that's why I tell everybody no bending and no lifting for you know, a year. You have to basically protect yourself for about a year while you're healing. So, great question. But it's basically restrictions, patient restrictions that keep them from re-injuring themselves after the surgery and re-herniating, having another herniation. Man. How's my irrigation? I just have a lot of red blood cells, but I have a little oozing. Huh? Stand by. Yeah, I don't know if it's just not under pressure or what. I don't know. I mean, that's between you and Luis. I think oh, there's a big herniation right there. You guys see that? Wow. That's a beast. Here it comes. All right, let's get the light on and show everybody. Get the blue towel. It's better to see. Can you see that,
Yeah.
Henry?
Yeah. We see it.
Okay.
Oh, wow.
Big piece. Just sitting there. Now that's a piece that we shoved back in. Lights off. That we shoved back in.
Thank you.
When we went through the annular tear, remember in the beginning with the dilator? At the very beginning of this disc? Laser. Just about done. So I'll take any other questions you have because we're going to be wrapping this broadcast up in about 2 minutes.
Oh, we just got a question. Comes from Ben Price, again, on YouTube. And he asks, does a patient have to have a disc with a certain amount of thickness remaining, a minimal number of tears, etc., a certain disc health to be a good candidate for this procedure?
Yeah, hey Ben. Nope, you can have basically bone on bone, 95% of your disc gone. And the reality is if you have 95% of your disc gone or 99% of your disc gone and you're having pain from that disc, then it's coming from this area I'm in right now, in the back of the disc, right where the tear and herniation are. So this last bit of whatever you want to call it, disc or herniation that's left, this is where the pain comes from. And I could still get it as long as the bone hasn't fused together. If the two bones are fused and the disc is completely fused, then there's no reason to do this surgery. It won't help. But if there's still some movement going on at those two bones at the back, the two vertebrae, then even if you have a degenerated disc, this procedure will still work. There's no minimal number of tears. I've seen big tears, little tears. Remember we talked about this the other day if you were here. Tears on the front of the disc don't cause pain. Tears in the back of the disc cause pain. And tears on the side of the disc don't cause pain. So it's only tears in the back of the disc that actually are painful. And that's because of the nerve fibers that are in the back of the disc. You don't find those nerve fibers in other parts of the disc. Stand by. Those nerve fibers are called somatic afferent fibers. Laser. Yeah, we're going to have her asleep for a bit longer because we're going to be doing the plasma. Okay? Just lay still. All right, looking pretty good. Look at that vein right there, folks. You see that right there at the top?
Yeah, we
That's
see
a
it.
vein. That's called an epidural vein. It's located just behind the disc. You see a little bit of fat right there as well, the yellow stuff to the left. All right, how are we doing, guys? Am I able to proceed? All right, just about done here. And then we'll be done. So any other questions from our audience?
No current questions.
Great. Well, I need 30 seconds on this and then we'll go to the plasma. Thank you all for watching. And we have one more surgery coming up. What's our last surgery anyway? Three level, all right. Done here. I'm happy with that. Yep, that looks good. Pardon me? Yeah. Oh, no. Yeah, so if there's no more questions, we'll end the recording.
Yes. All right.
Thank you for watching. We'll be back in 45 minutes for the last case.